A very
Can I
good
make
evening.
this full? Okay. Sorry.
A
Yeah.
very good evening to one and all. On behalf of Classroom Series and Neurocritical Care Society of India, we have with us a very important speaker, Dr. Madhusudan Rao. Sir is a DM in neuroanesthesia and neurocritical care from Shri Chitra. He's done his fellowship from STPGI Lucknow. Presently, he's working as a consultant in neuroanesthesia and neurocritical care at Ramaya Hospitals. Sir will be talking to us about a very important topic in the intensive care unit, which is nutrition. Over to you, sir.
Good evening, everybody. First and foremost, I'd like to thank Matangi and the team, Neuroanesthesia and Neurocritical Care team, for giving me this opportunity to present on this platform. With this, I would like to start the topic, which is the role of nutrition in Neuro ICU. Generally, this is a common topic where most of us feel that yes, we are doing our best for the patients, but are we really doing our best for the patients, or or what? I mean, or does it have any significant role in the improvement in the patients or not? Let's have a look at that. Okay, so coming to the thing, critical illness renders a patient prone for malnutrition. This is a common thing which all of us know. Why? Well, what are the reasons? The reasons could be in neurosurgical or neurological patients could be as simple as low GCS, where they are unable to take anything orally. There could be loss of appetite, nausea, vomiting. They can have RT aspiration and GERD. Patient might be having difficulty in swallowing or gastroparesis. They'll be on ventilator, prolonged mechanical ventilation. There again, it will be difficult for them to have a oral or enteral feeding. There could be secondary underlying endocrine and a massive inflammatory response, due to which it can cause malnutrition. They'll have a prolonged recovery because of the same, and they can be having a complication like sepsis or pneumonias. So malnutrition in critical ill patients can cause increased morbidity and as well as mortality. So this is where the importance of nutrition comes into play. Uh, yeah. So coming to the overview, we'll first go in the following headings. First is let's have an assessment about nutritional assessment of the patients. Followed by we'll try to do nutrition practice, the role of any disease-specific nutrition, whether there is any such disease-specific nutrition which will improve the outcomes, and what are the documentation practices and documentation that is required, and monitoring tolerance and adequacy of the feeding. Coming to the pathophysiology, as we all know, if there's any primary brain injury, whether it's because of traumatic brain injury or a stroke or a seizure, there will be a lot of there'll be an entire cascade of inflammation that goes on within the brain and the spinal cord, depending upon the area of inflammation, and of course the generalized body. There could be neuroinflammation causing severe catabolism and leading to metabolic crisis, and there will be oxidative stress, immune suppression, and malnutrition. This becomes a vicious cycle, and the cycle continues. In a short-term complication, this can lead to muscle weakness or atrophy, and fever and infection. This is one of the major culprits which causes secondary brain injuries and hence leading to long-term neurological disability. Sepsis, BOTS, prolonged bedridden status, malabsorption, and all the various conditions can further exacerbate the secondary brain injury. If we intervene at the right time, that is, if we start giving the patient with optimal nutrition therapy, there could be cellular homeostasis and improved neurological recovery. So now, yeah, well, there are many guidelines which talk about nutrition in critical care settings, but where we have very few guidelines which says about in neurosurgical or neurocritical care units. Of course, we have the Brain Trauma Foundation guidelines, which is 2016 regarding the nutrition. Then we have the ESPN European guidelines. We have the American guidelines. We have various other countries which have given their own guidelines. But currently, we have one practice guidelines for nutrition critically ill patient. This is a relook for Indian scenario. But however, they are primarily concentrated on the general ICU rather than a neurosurgical ICU. Uh, so we see is uh, what can be extrapolated into our ICUs based on them. Uh, Based on the Brain Trauma Foundation in 2016, which gives our nutritionists, there was no insignificant evidence to support level 1 recommendation for this topic. Level 2 is feeding patient to attain basic caloric replacement by at least fifth a day or maximum by seventh post-op day is recommended, okay, to decrease the mortality. And level 2B is transgastric jejunal feeding is recommended to reduce the incidence of VAP. So these are the only recommendations given by the BTS guidelines, and not much has been dealt in detail regarding the nutrition aspect. Coming to the prevalence of malnutrition in ICU, why is it so important? Malnutrition. Why do we have to bother about this? Is because the overall incidence around the world is around 38 to 78%, which is quite high. Even in the well-developed countries like US, UK, and Canada, the incidence ranges somewhere from 30 to 50%, and in India, it's somewhere around 40 to 50%. Okay, this is based upon a study done by Chakrabarti et al., which was published quite back in 2013 regarding the Indian scenario. But however, he did not include neurosurgical patients in this study. Coming to the screening assessment and what are the Indian practice guidelines that has been placed. These guidelines can probably hold good for all the patients, including our own patients. So nutrition status can be assessed via the subjective goal assessment, which is a 3B level of evidence. The initial monitoring of nutrition intervention must be done on a daily basis, and the nutrition plan should be monitored accordingly. This is the level 1A1 evidence. It's imperative that nutritional assessment is done by a well qualified and a trained nutritionist and who's dedicated to an ICU. That is the level 1 ICU. So here, what we have to have is a trained nutritionist should be dedicated to a person, to a patient, to ICU particularly, and the nutritionist to the critical care patient should be at least 1:25. That is C, level C. We have other gadgets through which we can assess the lean body mass, which mainly are the CT and the USG. But that is a B, level B5 evidence. Uh, One of the most common score that we monitor in the ICU is the Nutrix score. Nutrix score is a very reliable source or a reliable score for assessing the patient outcome. Well, what we use currently is the modified Nutrix score, which has age, comorbidities, days in the hospital to the ICU, Apache score, SOFA score. Unlike the primary Nutrix score, it does not include the interleukin 6 values. So modified Nutrix score, if the level is anyway, the total count is between 0 to 4, patient has a good outcome. And patient, if the level score is high, between 5 to 9, they have a high mortality and morbidity, and they need to be treated with aggressive nutrition therapy. There are various technical tools to assess the nutrition. First being a CT scan, which is cannot be done on a day-to-day basis. Second, we have a musculoskeletal ultrasound, which can be done on a daily basis. And of late, we are using even bioelectrical impedance analysis. Coming to each of these slowly, uh, CT CT measurement for the sarcopenia index. That is nothing but for malnutrition. Okay, this is in this slide we can see the CT of an abdomen taken at level 4, L4, lumbar spine 4 level, where in the bracket what we see in the box what we see is a psoas muscle. So now this psoas muscle, we're looking at the density of the psoas muscle. Okay, so this happens to be a person from taken from a general ICU who had abdominal distension and abdominal uh, uh, intestinal obstruction. So they are done repeated scan. That's why we can do in this thing. The first scan was done on day 37, and the next scan, this scan was done on day 45, fifth. As we can see, the in the day 45th, there is definitely more hyperdensity of the uh, source muscle compared to the day 37. So when they saw that the density decreased from 55.1 plus or minus 18 HF units to 46. Okay. So the total, so actually the normal density of the source muscle is somewhere between 50 to 60. So definitely the density of the source muscle has decreased, which means that the muscle is undergoing more of fibrosis. There has been muscle mass has been replaced with fibrotic tissues, which means that patient is having malnutrition. Coming to musculoskeletal ultrasound, this is something that we can do bedside. We have various techniques in which we can do bedside ultrasound for musculoskeletal. Most commonly, what we do is in the thigh region where we take the vastus lateralis, okay, and we can take also in abdomen and other places. So in the first area, quadriceps, in this thing, we take a measurement between the anterior iliac spine to the knee, and in between 3/4 junction of this length, we scan the muscle. Okay, now this is called the quadriceps femoris area. What we are looking at the area. So when we scan the area, we should be able to this line. What we can see, I hope you're able to appreciate on the screens. This is what this is femur. Okay, and the muscle above that. This is the quadriceps femoris. Okay, here the probe is kept perpendicular to the long axis. When we turn the probe into 90 degrees, we can also see the total density of the muscle. Okay, here we'll be able to appreciate better because we can see the various fibrotic changes, the anatomy of the muscle, and etc. And we can ask the patient, I mean, if possible, to contract the muscle, or so we can also see the muscle contraction and relaxation. Okay, so based on this, we can look at the volume. Okay, and then we can come out on a serial day-to-day assessment. We can assess whether the patient is having muscle atrophy or not. This is another thing about the abdominal area. Here, what we are considering is looking at the abdominal fat. Fat loss will be one of the commonest thing in malnutrition. So we mark a line between the xiphisternum to the umbilicus, and somewhere in between we scan for the ultrasound probe using a uh, ultrasound probe. Yeah. So what we are looking at is the fat density. I mean, how much is the fat from the superficial tissue. So based on this, we can serially monitor the abdominal fat in these patients, whether it's increasing or decreasing. Based on that, we can assess the nutrition status. Well, yeah, here we can see that quadriceps is here contracting, but here it is relaxing. So we can see that the changes in the quadriceps femoris. And we also can, in certain conditions, we can also see if there's any fasciculations, like amyotrophic, like AML conditions. We can see whether the muscle is contracting or fasciculating. There's something called as the the pennation angle. The pennation angle. Okay, I'll be just talking about it. The angle of pennation means is defined as angle at which the muscle fiber is arranged with respect to the force generating axis of the muscle on the muscle thickness. So basically, what it means is at which angle is the muscle contracting. Okay, so when we look at this is the PA angle. Okay, here this is the quadriceps femoris muscle, and you can see the cross section also. Here, these are the fibers for the hyper dense. You can see, I mean, hyperechoic structures. You can see. So these, when it form the angle, this is what is called as the angle of pennation angle. Okay. So healthy muscle tissues, they are seen as echolucent, that is dark areas, which is interspersed with bright, small curved echoes. The thicker lines represent the septum or the lining fascia. Normal muscle architecture is changed because of increased fat content. There could be fibrosis, there could be loss of healthy muscle, and inflammation, leading to increased muscle tissue sound reflexes. Okay. Due to this, the bone shadow can also be lost. Okay, or the bone shadow may not be seen properly. So the dynamic changes in the muscle, like fasciculation, can be seen in patients with ALS. This is a classical description, classical diagnostic feature in these patients. The other muscles that can be looked is triceps, biceps, quadriceps. Okay, why is it significant? How do we interpret this in terms of mortality? For every 1% loss of quadratus femoris thickness and the vast quadriceps intermediate muscle, in the first week of this disease, it was seen that 5% had increased 60-day mortality. That means definitely this has a mortality. We can assess the mortality based on this, and this is an indicator. Coming to the bioelectrical impedance analysis (BIA). So generally, we see this nowadays in most of the gyms, or else in the other program systems, like where they give us the entire body content of the fat, muscle, bone, water content, etc. Okay, so basically, it is having a bioimpedance technique where they'll be giving into all things in a very systematic way. Uh, so based on this, we can have a serial assessment, and then we can decide, like we can see that which component is getting lost, whether it's the water content or it's the fat or the muscle or anything else. The only difficulty is in our patients will not be in a position to stand, but however, this can be done preoperatively for elective or semi-elective patients, if possible. Now, coming to the estimation of the energy and protein requirements. So, I mean, There are so many formulas in which, based on which we can, it was decided whether protein should be given an X amount from the and it should be given a Y amount. But those are all the formulas are of historical benefits now, and they're very complicated, very cumbersome. Hence, the current indication is the indirect calorimeter. This is considered as a gold standard for measurement of energy requirement. The prediction is based on anthropometric minute ventilations are not always accurate. Other equations like the Harris-Benedict rule are all obsolete. As we can see in this, the Harris-Benedict equation is quite complicated. Uh, okay, there's another called as Toronto formula again for calculating the energy in this. As Toronto formula is especially for post-burn patients, which are not used nowadays. Coming to the nutritional requirement in neurosurgical patients are proteins, whether it's plant-based or animal-based. Preferably, of course, in ICUs, we prefer the plant-based proteins. Uh, Apart from the protein powders, which could be animal-based also, the proteins is around 1.2 to 2 grams per kg per day. This is the level 1A recommendations. However, the protein content could be increased based on a particular patient condition, which is titrated to each patient. The caloric requirement should be around 25 to 30 kilocalories per kg per day. That's also level 1A evidence. In certain condition where there will be like severe hypercatabolic state, like a patient with severe head injury, severe sepsis, burns, etc., the protein to the calories to the nitrogen ratio can be increased even up to 120 to 1. So they would need a very high caloric requirement compared to the protein requirement, and that should be met. And this is only in a certain conditions. When we talk in terms of glucose, the lipid requirements, we talk glucose should be around 2 to 3 grams per kg, whereas lipids should be around zero point 0.5 to 2 grams, etc. The various electrolytes which are mandatory for our day-to-day homeostasis, day-to-day routine work, which are sodium around 1 millimoles, potassium is around zero point 0.9 millimoles, phosphate zero point 0.3, magnesium is 0.04, and calcium, of course, zero point 0.1. Coming to the timing of feeding, so when do we, what are the recommendations regarding the timing of feeding? When should we start feeding? Can we wait? Initially, patients used to be kept NPO for many days for the surgery or post-operatively in the ICU, but currently that practice has been changed thanks to the new guidelines and research. uh, as far as possible, enteral feeding should be started within the first 24 to 48 hours in all neurosurgical patients who can take orally or through enteral feeding. They should also, at the time of the starting the feed, the observer should always look for the signs of malnutrition, like if there's any cachexia, edema, or any muscle atrophy, and this is critical. This is a level 1A evidence. If 50 to 60% there's failure to achieve oral feeding or enteral feeding by 50 to 60% within the first 48 to 50 hours, then we should start thinking in terms of tube feeding. Okay, this is again for patients who are in conscious sitting. Otherwise, we should start tube feeding as early as possible. But for any reason, even by the seventh day, we're not able to achieve the targeted enteral feeding for that patient. It is imperative that we start thinking in terms of starting parental nutrition, or at least we better start parental nutrition as early as possible. So here we have a picture where we can see that this is an endotracheal tube. What are the methods of this thing? Of course, we all know this endotracheal tube. Sorry, Riles tube. I beg your pardon, Riles tube. Then we have a nasogastric tube, nasojejunal tube, where the tube is placed in the jejunum. This is done by the gastroenterologist. This is probably the preferred method by which feeding should be given, because by this reduces the gastric volume, and thereby it also reduces the GARD and the reflex. Here we have a patient who has undergone PEG, percutaneous uh, gastrostomy. Currently, the kitchen feeds are no more recommended, okay, because there's always a risk for infection, poor hygiene of the persons handling it, or even the storage. So, hence, if feasible, this is not recommended at all. Uh, in other ICUs, like what we use in our ICU, what we use is we use a continuous feeding bag where the nurse handling, taking care of the patient hardly handles the feeding again and again. They just pour the entire content of the feed into the bag and let it go slowly, and feed is given continuously. So this is one of the better techniques to prevent regurgitation, vomiting, and is tolerated better for the patients. However, the preformed feed, okay, which is already uh, packed, is what is currently recommended with moderate recommendations. This is is a close loop it will maintain, where directly it can be started to the patient through RT and without any chance of contamination. However, the cost is a big factor in this. What are the recommendation? NG route should be the first choice of enteral feeding, then jejunal route, which is level A1. Continuous formulation feeding with pump or gravity bags can be performed uh, using a tube, and I mean rice tube. These are the supplementation of vitamin and minerals, which was done in lab studies. Okay, where we have all vitamins B1, I mean vitamin A, B1, B3, B6, folic acid, and they all have been shown to have some benefit. However, none of them have been proven to have a level 1A evidence for any change in the outcome. But however, definitely they all reduce. They act as antioxidants. They do help in cellular regeneration at various doses. B12, B12 folic acid helps in the neural generation. Folic acid and vitamin C and vitamin E can be given to reduce oxidative stress. However, there has been contrasting evidence regarding vitamin C used. Vitamin D can be used in these patients uh, who are having with definitely a vitamin D deficiency, especially. Okay, other elements are zinc and selenium can also be given. They also have antioxidant effect. Coming to the recommendation in obese patients. Okay, so in obese patients, energy is energy based on the total body weight (BMI). If the BMI is anywhere between 30 to 50, the we need to give around 11 to 14 kilocalories per kg of actual body weight, not the total body weight. Okay, this is as per the Aspen guidelines 2016. If the BMI is more than 50, so we should be giving them at 20 to 25 kilocalories of ideal body weight. Proteins is again 30 to 40 BMI, 2 grams per kg, more than 40, 2.5 grams per kg of ideal body weight. There's a term called a permissive underfeeding, where we can give probably a little bit of undernutrition to these patients, and it has been shown that it reduces the ICU stay and also improves in the other parameters, and it helps in better patient tolerance. The practice guideline says intentional underfeeding can be restricted to specific indications level A1. A whose patient can be subjected to underfeeding. This is one concept that is slightly different from what we come across. Coming to the patients who are hemodynamically unstable, most of our patients might be receiving multiple inotropic support like noradrenaline, vasopressin, etc. So there was always a confusion regarding to start enteral feeding or not, because the gut would accept it or not. So based on that, this is a formulation given by our Indian society, uh, and is not generally seen in other guidelines. So the clinical monitoring of gut function should be started as early as possible if patient is hemodynamically stable. Once patient is having been fluid resuscitated, okay, and is having a declining doses of less than 2 vasopressors, enteral nutrition may be started uh, continuously at a very low rate. Okay, so what you do is, if patient is having less than 2 vasopressors and patient seems to adequately fluid resuscitated, so you can start enteral feeding continuously infusion at a slow rate. You don't have to continuously give a high volume. Uh, enteral feeding should be administered within first 48, 24 to 48 hours once patient is stable with vasopressors. Okay, if persistent shock is there, only in that case our patient is requiring very high inotropic support, then probably enteral feeding could be avoided, level 1A. Enteral feeding plus parenteral nutrition are not commonly routinely recommended, but depends upon case to case. So we need to titrate this based on each patient. Coming to the tube feeding and the nosocomial infection. So yeah, currently there's a scare among the intensivists across the world saying that by giving tube feeding, especially the kitchen feed, there can always chance of having infections. So what is the evidence for that? The local term long-term enteral tube feeding with elemental diets is common risk factor for Clostridium difficile colitis. This is a common organism, which is very notorious for causing diarrhea in these patients. However, the most difficult part is to identify it. So we should have a very high suspicious for these organisms. If at all you're suspecting this organism, you have to send the culture, stool culture, and you'll be able to get the culture report. Contamination and inconsistency are more likely with the blenderized feed than with the scientific feed. Scientific feed basically means the preformed feeds. Uh, Blenderized feed is the kitchen feed. So, what are the factors which are responsible for causing bacterial contamination? This is not there are high chances that there could be high unhygienic food items itself, or the cooking process is not sterile, or the devices and the blenders which they are using is not cleaned properly. The hygiene of the floor and air conditioners are not working properly in the kitchen, and the kitchen environment is quite. There could be other infestations in the kitchen, which is commonly seen at least in our part of the country, or in at least the second, third world countries. There could be negligence by the kitchen staff or the nurses or any person who's handling the food items. There could be impaired, improper food carriage process. So even the carrying process of the how they are transporting the food to the patients, that process could be faulty. Hence, there are multiple loopholes where nosocomial infection can be can occur. Okay, for the patients, food poisoning. Well, when we use a closed system or ready-to-use formulas, they are less prone for bacterial contamination because it's a closed system. There is no nurse or patient handling anything. All we have to do is remove the cover and uh, connect it to the patient. Feeding-related nosocomial infection in critically ill patient can be prevented by maintaining sterility of the formula feeds. But irrespective of the kind of the feed, we should always maintain proper hygienic condition when we are giving feeding to the patient. So what are the practice guidelines? Scientific formula feeds should be preferred over the blended feeds to minimize the feed contamination. This is level 3B. Whenever feasible, closed system ready to hang formula feeds should be preferred. Again, level 3B. Blend rice formula are most likely to have bacterial contamination than other hospital prepared diets. This is level B4, which is again common, but hygienic methods to feed preparation, storage, and handling of both formula feeds and blend rice feeds are necessary. Level 3B. A continuous feeding bag could be used. So this is level 2, 3, 3 2. Okay, so basically, they prefer to use a continuous uh, feed. Okay, in these patients. Okay, especially with ready to hang formulas, rather than using blenderized feed. Excuse me. So now, how do we monitor the tolerance and adequacy of the feed? So as per the ASPEN's guidelines 2016, so we have a gastric residual volume. GRV is gastric. Ideally, in our ICU, we commonly see that the sister would have given feed to the patient, and after 2 hours or 3 hours, she'll put a suction catheter and she'll aspirate, and quite a lot of around 200 300 ml of the feed will come again. So ideally speaking, this should be avoided. Gastric residual volume should be measured only with the help of a syringe aspiration and not with the help of a suction pump. Level 2A, any gastric residual volume of less than 300 can be refed. So there's a lot of myths regarding this topic, because patients having even 100 ml or 150 ml of arterial residual volume, they're being kept NPO by various people. So this should be avoided. So according to the Indian standards, yes, anything less than 300, please give the patient feed. Defeed. Do not keep the patient starving. Holding enteral feed for gastric residual volume less than 500 ml in the absence of other signs of intolerance should be avoided. This is level 1A. That means if the patient is not having any abdominal distension, patient is hemodynamically stable, there's no melena or upper GI bleed or any other tense abdomen or any other signs, please do not withhold enteral feeding. In Indian scenarios, what we are taking is cutoff value of around 300 to 500 ml. Okay. In case the gastric residual volume is very high for a patient, we should prefer to use a continuous feeding, by which we'll reduce the volume that is being given to the patient at any given point of time, and that will be easier for the patient to tolerate. Prokinetic agents like metoclopramide or erythromycin can be recommended in patients with intolerance and the risk of aspiration level 1A. However, metoclopramide to be used cautiously in neurosurgical patients, neurological or neurosurgical patients. Coming to the how do we assess the gastric wall assessment, this is a part of the focus nowadays. So we use a probe, we keep it in the midline, slightly tilt both towards the right side and the left. Okay, uh, to look at the pyloric junction. Okay, so in this image, what we can see here is this is the liver. Okay, this is the liver, this is the cephalate side, this is the skin, and this is the caudal side. Okay, so here we have a liver. Then this is a circular structure. What we see here is the antrum, gastric antrum. Okay, this is the pancreas, and there will be superior mesenteric artery, and aorta will be low. So when we look at the ultrasound image, okay, this is a pictorial representation. Same thing, we can see the skin. Okay, we can see the antrum here, the hypoechoic structure with a circular hypoechoic structure, and here we can see the liver shadow, and followed by pancreas, and under beneath the pancreas, SMA, and aortic artery. So now, how does an empty stomach look like? This is something probably we can do even for patients who come for emergency surgeries. If the stomach is empty, okay, then the gastric antrum will be collapsed, will be closed. It looked like a proper mass. Okay, so I mean, there's no in this, there's no. It's a circular structure which will be closed. Okay, so gastric antrum looks small, it's not distended, it looks like a bullseye appearance. That is a classical description, bullseye appearance. Okay. But however, if the patient has had an oral feed, I mean, sorry, he has taken a feed by gastric, by feeding the for by, I'm sorry, patient has had feed or water, what we can see this gastric antrum, the and opens up, okay, and we can take the cross section areas to know the volume of the gastric residual volume. There's always interaction between, there's a cause for diarrhea and there's a reason being enteral feeding. So what is it? Diarrhea, when do we say it's diarrhea? It's when patients having three or more low stools per day, which is liquid in consistency. So in these cases, if you have ruled out all other cases causes for diarrhea, probably enteral tube feeding could be one of the reasons for this. Of course, this is a diagnosis of exclusion, not inclusion. So what are the practice guidelines? Enteral feeding should not be interrupted in the event of diarrhea. So this is level 1A. Okay, because with the various causes for diarrhea, and probably we can control it, but keeping a patient NPO just because of diarrhea is not recommended. It is in fact more dangerous for the patients. Feeds can be continued while evaluating the etiology of the diarrhea. Again, level 1A. You can send the stools for examination, microscopic examination, also do for culture. Okay, look for any blood in the stools or any other, whether it's diarrhea or dysentery. Look for any other abdominal causes. So always you can diagnose that. The use of soluble fiber containing formulas or a small peptide semi-elemental formulas. This is currently available in the market, which we are giving to our patients in a divided doses over 24 hours. May be benefit to patient with persistent diarrhea. Okay, like again, after exclusion of, the most common thing that we need to exclude here is we should not be giving any hyperosmolar agents to the patient, and of course the clostridium difficile infection, as we already spoken about. It's level 1A. Routine use of probiotic across general population of ICU patient is not recommended. Probiotics can be used for a tailored made for each patient who requires. Coming to micronutrients, what are the importance of micronutrients? Why do we need micronutrients? As we know that there's a massive uh, inflammatory response occurring across the body, the brain, across the, not only the brain, there's brain heart interaction, brain muscle, all interactions are going on. There'll be extremely high redox imbalances happening, causing systemic inflammatory response syndrome. There will be mitochondrial dysfunction and multi-organ failure. The causes being pre-existing malnutrition could be there, severity of the current illness, or the any drugs that can be causing drug side effects could be causing. What are the consequences? This decreases the immunity. So hence, once immunity comes down, the chances of infection and the vicious cycle goes on. There could be compromised wound healing. So surgical wound gaping is one of the commonest thing. There could be increased morbidity and mortality. So this is very important thing. Selenium is considered one of the most important micronutrient that probably needs to be administered to the patients. What is the role of immune enhancing enteral nutrition? It's been available quite freely in the market nowadays. So immune modulating nutrients such as omega-3 fatty acids, selenium, antioxidants, antioxidants modulating inflammatory and oxidative stress response, and they impair the immune function also. They improve in, immune function. So patients who are suffering with severe traumatic brain injury or ARDS or severe sepsis are the ones where we can initiate this supplementations. We also have glutamine supplementations. It has been found that it reduces the nosocomial infection. It reduces the hospital stay in critically ill surgical patients. However, it does not have any mortality benefit. So again, you need to titrate this use for a patient base only. So one of the practice guidelines says, this Indian practice guidelines, immune modulating nutrients should not be used regularly or routinely. This is level 1A. In ICU patients with a very severe illness who is not tolerating more than 700 of enteral feeding formula per day, immune nutrients should not be used. So this is another important thing where the patients for some reason is not tolerating the enteral feed for more than 700 ml. You should not be giving immune modulating drugs to these people. Immune modulating nutrients should be considered for patients with severe traumatic brain injury or perioperative patients in surgical ICU, neurosurgical ICU, level 1A. Glutamine is not recommended in clinical and critically ill patients with multi-organ failure. So this is level 5B. Okay, so this is again, like I said, it should be used with caution. It should not be given as a blanket therapy for all the patients. What are the standard nutritions in TBI? Okay, coming to the disease specific, what we can say is, okay, as we know, the TBI is hypermetabolic and a hypermetabolic state. There's increased risk of muscle wasting, tissue atrophy, muscle wasting, muscle loss, negative nitrogen balance, and malnutrition. So, as per the BTF guidelines and the guidelines that we have come across, all the guidelines says please start the feeding as early as possible, preferably less than within the first 24 hours, to or maximum between fifth to seventh day. You should be able to achieve the entire nutrition targets. As soon as volume resuscitation is completed, the patient, if is stable, please start the entry feeding. Do not waste time. So what are the practice guidelines? Initiate enteral feeding after post-traumatic period within 24 to 48 hours once patient is stable. Protein recommendation should be around 1.5 to 2.5. Here the protein recommendation is slightly higher compared to a patient who's stable in neurosurgical ICU. Arginine containing immune modulating formulas or eicosapentaenoic acid or docosahexaenoic acid supplementation the standard enteral formulation TBI patients is recommended. So these are again some of the supplementations which have been found to have probably have a better outcome in these patients. Well, we do come across patients coming to us in a hepatic encephalopathy or hepatic failure, patients coming with drowsiness. So, what are the guidelines says about them? Okay, so enteral feeding is preferred in both acute as well as chronic liver disease patients who are admitted to the ICU, level 1A. There are a lot of myths regarding the branched chain amino acids. So, hence, this guidelines clarifies clarifies it. There is no beneficial effect of using branched chain amino acid, which is level 1A, unlike the contrary to the previous beliefs. Protein supplementation is recommended in liver failure. Again, there's a lot of myth regarding supplementing the proteins in these patients. Generally, people tend to give a protein restricted fluid diet in these patients. However, they should not be done. Protein energy determination should be done on a dry body weight or usual weight rather than instead of actual weight. So level 1A, because these patients are prone for having anasarca or ascites, etc. So they should be using at a dry body weight. The protein restriction should be avoided in refractive encephalopathy. 5B. Calories and proteins. Here again, the calories are around 35 to 40 kilocalories per kg only. Proteins is we are restricting slightly, but not we're not going up to the 2 grams per kg, but we keep it around 1.2 to 1.5. So you start with 1.2 grams of proteins and slowly escalate it to 1.5 grams per kg per day, as tolerated by the patient. For this, we need a serial assessment of the patients, and which should be in a ICU norm. Uh, if patient is having sodium abnormalities, kindly tailor the whether sodium restriction is needed for these patients. We also come across a lot of patients with CKD or coming to our ICU with a stroke or else a large intracranial bleed, or patients coming to ICU with multiple trauma, head injuries, landing up in acute kidney injuries. And because of this acute kidney injury or a chronic kidney injury with acute exacerbation, um, their mortality and morbidity chances increases. Okay. So what is incidence of AKI in ICU is around 20 to 50% in India, but the mortality rate is more than 50%. So this is where is alarming, and we need to give proper care for these patients. As we know that AKI or CKD is a hypercatabolic state, and renal replacement therapy further worsens the protein and micronutrient losses. What are the practice guidelines says? They say the standard enteral formula is recommended for ICU patients with AKI. Again, you should give them the standard feed. Protein should not be restricted in these patients. So this is also a myth that previously thought that protein should be restricted. However, the current guideline says please do not restrict proteins because they are already losing proteins in the body from the body during dialysis or otherwise. The daily proteins again should be started with 1.2, slowly escalated to 1.7 grams per kg of actual body weight in these patients. If there is any significant electrolyte imbalance, kindly adjust it during the dialysis or accordingly. If low potassium and low phosphate diet can be implemented, because these both are extremely important elements for normal homeostasis. So, what documentations are necessary for nutrition practices in our day-to-day ICUs? So, practice guidelines says that we should be having a documentation for patient body weight, and it should be reviewed on a weekly basis. Is recommended. Level 2A recommendations. Documentation of the below mentioned is also recommended, like screening and assessment tool used along with their scores and weekly review scores. Nutrition care plan on a daily basis. What are the plans for a patient on day-to-day basis? Any infection complications, stool frequency on a day-to-day basis has to be assessed. So this is the role of nutritionist, and of course, it's not only the nutritionist, even the anesthesiologist. Even we as new anesthesiologists should be taking participate in these things, and assessing this on a day-to-day basis. So. Uh, uh, I'm not covering much of parental nutrition. Parental nutrition, to say briefly about it, we have basically total parental nutrition, which could be either central line guided or else to peripheral line guided. Based on the total energy requirement, we have a different formulation that is available currently. Since it's not routinely used or it is used as a backup plan, I'm not covering it. Can you pardon me for that? So, what are the take home messages? Daily nutrition assessment is imperative in neurosurgical ICU patients. Start feeding as early as 24 hours. Tailored made for each patient. So the diet has to be tailored made for each patient, for his own complications, for his conditions, pre-morbid condition, and etc. Please avoid prolonged NPO status. Do not keep patients NPO for procedures like tracheostomies or small craniotomies or VP shams if the patient is in ICU. So please continue RT feeds, and that will prevent the further morbidity and mortality of these patients. With this, I like to complete my topic. Thank you so much.
Okay. Thank you, sir. Thank you for that wonderful talk. Just a few questions. Like, as a protocol, do you have anything which you kind of do you follow in your ICU for nutritional assessment in a regularized way? I
In
know
a
it's
regular,
a
yeah,
challenge. So,
yeah, it's a challenge thing. As a protocol base, we don't have any fixed protocol as of now. But one thing is, we start the feeding as early as possible, preferably sometime less than 6 hours, or maximum by first 24 hours we start the feed. We use a continuous gravity assisted bag for our patients, and we're giving continuous feed to this patient. With this, what we have seen over the last couple of years, that the patients having intolerance to the gastric feed is very less, very minimal. Patients are having good acceptance with this. We're also supplementing them with the basic other vitamins, of course, which is given, and vitamin D based on their level of deficiencies. With that, also, we have seen that the wound healing and the overall recovery is slightly better. Of course, we don't have a fixed data to give a consolidated answer for that. Um then yeah, on a day-to-day basis, we are assessing the nutritional requirements, whether patient's having a hypercatabolic state, whether he needs, we change according to the patient stage of the patient's illness. Whether it's acute illness, we give them high caloric diet. If the patient is having in the intermediate stage, we continue with the normal recommendations. If the patient is weaning type, we not reduce the caloric content, but we like to modify the diet accordingly. So that is the basic thing that we do. Assessment wise, uh, we are not doing regularly ultrasound, but we plan to do it in the future
Okay.
for the
One more
patients.
question. I think the most important deterrent in our set of population is this NPO status of the
Yes.
patients. Like they
Mm.
have been kept NPO. So, what is your take on that? So, the ideal. I know it's not possible to comment on the ideal duration, but practically, what is possible to reduce the NPO duration for a patient?
So if the patient coming for elective surgeries, yes, 6 hours. Okay, the NPO guidelines is okay, but we do they can probably given medicines or else with water, and probably they can have tea, green tea, or what is recommended. Post-operatively, as far as possible, we don't keep them NPO for 6 to 8 hours or 10 hours. We start the feed as early as possible. The patient is on mechanical ventilation, or we start almost immediately. Even for a procedure like tracheostomies, or whether we're shifting the patient to shunt or redo surgery, we don't keep them NPO. We continue with the feed. We, during the in between, we just take them to the operation theater, finish the case, and come down. If it's a patient who's taking orally, yes, we give as much as tolerated. We prefer oral feeding only rather than IV fluids in these patients. Patients like myasthenia or neurological patients who are again on a long-term feeding in ICU, we prefer to undergo PEG because the gastrostomy their way will be reducing the chances of any having the sinusitis in these patients, and patient feels much better when the rice tube is removed and they're having PEG. It's better tolerated by the patient. Uh, so that is a thing we do. And if there's any diarrheas, we don't stop unless the diarrheas are more than 5 or 6 times in a day. Okay, we still continue with that. If the gastric residual volume is less than 200, what we do, of course, the guideline currently says 300, at least less than 200. We continue with the RT feeds. We do not stop them. So this is the thing. This is the protocol that we follow in our ICU. Yeah,
Thank you, sir. On behalf of Classroom and Neurocritical Care Society of India, thank you for accepting our invite on such short notice, and it was a fantastic talk. All of us learned something new. Hope to see you on many more forums like this. Thank you
thank
very
you so
much.
much. Once again, I'd like to thank you and the entire ISNAC and the Neurocritical Care Society team for giving me this wonderful opportunity to present. Thank you so much. Thank you.